Okay, it's being recorded.
Okay. Okay, ready. Okay. Good afternoon, everyone, and welcome to this month's Journal Club. So, as everyone knows, I'm Zaren, and I'll be presenting the latest mashup, the use of dapagliflozin on metabolic dysfunction-associated steatohepatitis, or MASH. So, before we dive into the article, I want you first to meet Katie. He's a 56-year-old male, single insurance agent from Toronto, who was referred to the clinic for type 2 diabetes management. So he was a previous 40-pack year smoker who stopped 10 years ago and an occasional alcoholic beverage drinker, about one standard size drink per month. He has a history of hypertension, dyslipidemia, obstructive sleep apnea, fatty liver, osteoarthritis, and has had a cholecystectomy. He has a BMI of 41.5 and A1C of 9.2. His ALT was 1.7 times elevated and also has an elevated ACR. His abdominal ultrasound showed a liver that appeared normal in size and showed increased coarse parenchymal apotexture, which may suggest a grade 2 fatty liver. He is on the following medications, including metformin, long and short-acting insulin, tirzepatide, ramipril, amlodipine, and atorvastatin. So for some, in other clinics, maybe it may be reasonable to simply titrate his insulin doses to get his A1C to target. After all, that was all he was referred for. And some patients may even ask why there is a need to add additional medications if he's already on insulin. But of course, we try our best to manage holistically and in a preventive manner as well. At the clinic, we would probably consider adding an SGLT2 inhibitor, not just for the glucose control, but likely also because of his elevated ACR. So today I will discuss the latest mashup, the use of SGLT2 inhibitors, not just for what we usually use it for, but also in the management of fatty liver, which is actually a common comorbidity among our patients with type 2 diabetes, just like Katie. So first of all, what is fatty liver? Formally, these are the terms used now. We have metabolic dysfunction-associated steatotic liver disease, or MASL, and metabolic dysfunction-associated steatohepatitis, or MASH. So it's actually the most common liver disease in Canada, affecting approximately 25% of the general population, and is often associated with obesity, diabetes, and or hyperlipidemia. It used to be called non-alcoholic fatty liver disease, or NAFLD, and MASH used to be called NASH. It was changed because non-alcoholic does not entirely capture the nature of the disease, and fatty was felt to be a bit too stigmatizing. So MASLD focuses more on the accumulation of the fat or triglycerides within the liver cells, or the other term is called steatosis of at least 5%, while MASH is steatosis with liver cell damage and inflammation. So steatosis is diagnosed using imaging techniques, blood marker scores, or by liver histology. This, in combination with type 2 diabetes, obesity, or these other metabolic risk factors, give us a diagnosis of MASLD. It is important to note as well that MASLD is diagnosed in patients with an alcohol intake of less than or equal to 30 grams per day for men, about two standard sized drinks, and less than or equal to 20 grams per day for women, about one drink, which differentiates it from alcoholic liver disease, or ALD, and that's usually diagnosed in patients with an alcohol intake of at least 60 grams per day. It's also prudent to rule out other concomitant liver disease if liver enzymes are elevated for more than or equal to 6 months through additional testing, like looking for hepatitis, autoimmune processes, and other things. So the term MASL is actually a spectrum of liver conditions ranging from just bland liver steatosis to MASH, and to MASH-related liver fibrosis and cirrhosis. So steatosis itself is generally considered to be benign. However, 2 to 3% of affected people may progress to MASH and develop advanced fibrosis or cirrhosis within 1 to 2 decades, even when ALT levels are persistently normal. In contrast, MASH is considered a potentially progressive disease in which ongoing liver cell injury leads to chronic inflammation and fibrosis, ultimately resulting in cirrhosis in up to 20% of individuals within 20 years. So MASH includes the steatosis, the ballooning degeneration, and the inflammation. And in cirrhosis, you will already have the fibrosis. So patients with MASLD are usually classified as high or low risk using the fibrosis 4 score. Lower score of less than 1.3 essentially rules out a significant liver fibrosis, and then higher than that is indeterminate or high risk, which usually warrants a referral to a specialist and further evaluation. So the goal of treatment is to halt or reverse fibrosis in patients with clinically significant fibrosis, meaning to avoid cirrhosis, end-stage liver disease, and all of its complications. So I'll briefly run through the current treatment modalities for MASL. Just like in type 2 diabetes, lifestyle modifications are the cornerstone of MASL management, including physical activity, dietary modifications, weight loss, reduction of alcohol intake, all things we similarly talk about with our patients with diabetes. Other things they consider include hepatitis A and B immunization. There's inconclusive and insufficient evidence for the use of fatty acids, omega-3 fatty acids in coffee as well. And of course, as we talked about last time, bariatric surgery should be considered as a therapeutic option in patients who meet the criteria, as it effectively resolves MASLD and MASH in majority of patients without cirrhosis and reduces CVD mortality. So for patients with indeterminate or higher risk, there are considerations in using vitamin E, PPAR gamma agonists like pioglitazone. The use of GLP-1 receptor agonists have also been seen to be effective in reducing fibrosis. There's also just one drug that has been approved by the US FDA. It's the only one that has been approved specifically for MASH, resmetirom, which is a thyroid hormone receptor beta agonist. Basically, it targets liver function to stimulate localized hyperthyroidism, reducing lipid accumulation and liver fibrosis without the systemic effects used with thyroid hormone therapy. There's also been studies on FGF21 analogs, and they are still being evaluated. So now, here's the latest mashup. What about SGLT2 inhibitors? So this study looks specifically into that. It's titled Effect of Dapagliflozin on Metabolic Dysfunction-Associated Steatohepatitis or MASH, a multicenter double-blind randomized placebo-controlled trial. It's also called the DEAN trial by Jiayang Lin and others. It was published in the British Medical Journal last June 4, 2025. So what makes this different from other studies is that the other studies that looked into SGLT2 inhibitors have proven or have shown that they can improve the non-invasive liver parameters such as liver fat content, liver enzymes, and liver stiffness in participants with MASLD or MASH. However, fibrosis itself hasn't really been looked into. And fibrosis is actually the most important prognostic factor in people with MASH. So looking into fibrosis regression is important as it can improve the long-term clinical benefit for MASH progression to cirrhosis. So the objective of the study is to assess the efficacy and safety of SGLT2 inhibitor, specifically dapagliflozin, in participants with MASH. For diabetic drugs, so far only semaglutide and tirzepatide have resulted in a statistically significant improvement on liver fibrosis without worsening of MASH in participants with or without diabetes. So it is a multi-center double-blind randomized placebo-controlled trial. It was conducted in 6 tertiary hospitals in China from November 2018 to March 2023. So the study based the possible use of SGLT2 inhibitors on MASH using the study of Liu and colleagues on mice in 2024, which reported that SGLT2 it actually increases the BDH1, which induces ketogenesis in CD8 T cells. These CD8 T cells actually produce a GZMB or Ganzan B, which is a protease which is known for its cytotoxic T lymphocytes and natural killer cells. So by reducing this GCMB, it reduces liver injury, inflammation, and fibrosis. So that's kind of the basis of why they think dapagliflozin can do this. So the participants were 154 adults with biopsy-diagnosed MASH with or without type 2 diabetes, who were 18 years or older, who had a non-alcoholic fatty liver disease activity score or NAS score of 4 or higher, with a subscore of 1 or higher for each subcomponent of steatosis, hepatocyte ballooning, lobular inflammation. So this kind of translates to the fibrosis 4 score that I showed earlier. It's a similar test or scoring system. And also the liver biopsy should have been done within 6 months before the randomization. So key exclusion criteria included liver diseases other than MASH, cirrhosis, excessive alcohol consumption, HbA1c of more than 9.5% at the time of screening, concomitant drug use that might affect MASH, just like the ones I mentioned earlier, pioglitazone, GLP-1, vitamin E, cortisol. Also, if they had a weight change of more than 5% between screen and randomization, as this is part of the initial management of MASL. So here's the flowchart of trial participants. The participants were first, of course, assessed for eligibility. Those eligible were randomly assigned to receive either 10 milligrams of dapagliflozin or matching placebo once daily in a 1:1 ratio. So the randomization schedules were generated using a computer program centrally, and participants were also stratified by the presence of type 2 diabetes. So they received the placebo or the dapagliflozin once daily for 48 weeks. All participants attended a health education session semi-annually. Assessment of body weight, waist circumference, BP, glucose, and liver enzymes were also conducted at baseline and at weeks 4, 12, 24, 36, and 48. Other things like physical activity, dietary intake, health-related quality of life, HbA1c, insulin, and lipids were also assessed at baseline and at weeks 24 and 48. Then the liver steatosis and stiffness using a fibroscan, and then the visceral fat area using an abdominal CT were also measured every 24 weeks. Screening biopsy results were used as the baseline, and then a follow-up biopsy was done at week 48. All biopsy findings were read centrally by 2 independent liver pathologists. The pathologists were unaware of the treatment assignments, participant characteristics, and each other's assessments. In case of any discordant assessment on any variable, a third pathologist was there to make the final decision. So from November 2018 to March 2023, 154 eligible participants were randomly assigned, again, to receive dapagliflozin, a total of 78, and placebo, a total of 76, once daily for 48 weeks. In total, 90% of the participants completed the final visit and 81% completed the end of study biopsy. The mean age of the participants was on the younger side at 31. 35.1 years, with a mean body mass index of about 29.2. Of them, 85% were male and 85% had dyslipidemia, 45% had type 2 diabetes. Overall, the characteristics of the participants at baseline were similar between both groups. Their mean NAS score at baseline was around 6, and a total of 33% of the participants had stage F1 fibrosis, 45% had stage F2, and 19% had stage F3. So for the outcomes, these are just some of the definitions. MASH improvement means a decrease of at least 2 points in the NAS or an NAS of less than or equal to 3 points. MASH resolution means hepatocellular ballooning score of 0 and lobular inflammation score of 0 or 1. Without worsening of MASH means without an increase in steatosis, ballooning, or inflammation score. Without worsening of liver fibrosis means there's without an increase of fibrosis stage, and fibrosis improvement means a reduction in fibrosis of at least 1 stage. So the primary endpoint was MASH improvement without worsening of liver fibrosis at week 48. Secondary endpoints included MASH resolution without worsening of fibrosis at week 48, fibrosis improvement without worsening of MASH at week 48, and changes from baseline to week 48 in each of the other subcomponents in NAS, fibrosis stage, liver enzymes, liver steatosis and stiffness, visceral fat area, metabolic variables, and other health-related quality of life. So for the results, the risk ratios, 95% confidence intervals and p-values were all calculated using the Cochrane-Mantel Hansel test, controlling for baseline diabetes status. The proportion of participants in whom MASH improvement was reached with no worsening of fibrosis at week 48 was 53% in the dapagliflozin group and 30% in the placebo group, with a risk ratio of 1.73 and a p-value of 0.006. In addition, the proportion of participants with MASH resolution without worsening of fibrosis at week 48 was 23% in the dapagliflozin group and 8% in the placebo group, with risk ratio of 2.91 and p-value of 0.01. The proportion of participants with improvement in fibrosis stage without worsening of MASH at week 48 was 45% in the dapagliflozin group and 20% in the placebo group, with a risk ratio of 225 and p-value of 0.001. When stratified by metabolic factors, and I specifically just looked into the diabetes, participants with diabetes seem to have higher proportions of fibrosis improvement with no worsening MASH at week 48 than participants with no diabetes. So treatment with dapagliflozin was also associated with reductions in each subcomponent of the histological features, including steatosis, ballooning, lobular inflammation, and fibrosis. So treatment with dapagliflozin was also associated with reductions in liver steatosis and stiffness assessed by FibroScan over 48 weeks. Likewise, liver enzymes like GGT were significantly improved in the dapagliflozin group as compared with placebo. Furthermore, treatment with dapagliflozin was also associated with reduction in body weight, waist circumference, and abdominal visceral fat, and also an improvement in lipids. Weight loss was found to largely mediate the total effect of dapagliflozin on the higher proportion of MASH improvement and MASH resolution, but the results also indicate that fibrosis improvement without worsening of MASH was actually independent of the weight loss. So for the adverse effects, there were about 56% in the dapagliflozin group and 64% in the placebo group. Common adverse effects included COVID-19, insomnia, and gout. DKA was only reported in one patient in actually the placebo group, but not in the dapagliflozin group. The proportion of participants who discontinued treatment because of adverse events was about 1% in the dapagliflozin group and 3% in the placebo group. And the common reasons were UTI and DKA. So in conclusion, dapagliflozin may affect key aspects of MASH by improving both steatohepatitis and fibrosis. Dapagliflozin provides similar benefits on MASH improvement without worsening fibrosis, regardless of whether the patients were living with obesity or not, diabetes or not, or with a different severity of MASH. Dapagliflozin also benefited the metabolic conditions which are strongly associated with MASH. Just some limitations. So this study was done predominantly on a Chinese population, may limit some broader generalizability. There was a high proportion of male and relatively younger participants as they were more willing to accept the liver biopsy at screening. And there are a scarcity of major adverse liver outcomes such as cirrhosis and hepatocellular carcinoma. So this necessitates a larger scale and longer term trial to confirm these effects. And these are my references, and thank you for listening to the latest mashup.
Wow, thank you, Zaren. That was very impressive. Dale, were you able to catch some of that presentation?
Yes, I was sitting behind Prince for the whole thing, and now I just walked back into my own room. I thought it was great, Zaren. That was and I think certainly behooves us in 2024. At the last Diabetes Canada meeting, the gastroenterologist or the hepatologists were present in force, talking about this, trying to get all of those diabetes caregivers to sort of take on screening for MASLD. By doing FIB4 calculations as part of our routine, which I think we all that week were like, yeah, that's a really good idea. And I don't think many of us have started to do it, but we all thought it was a really good idea. We should be looking for this more often. But at the same time, I've also been struck by, and it's similar to the experience with the cardiology group. So from the endo perspective, when we got GLP-1s and SGLT2 inhibitors and the cardiac data started coming out, we were all like, you guys need to participate in this. This is your drug now too. And I felt like it was slow to get started with cardiologists. It feels like it's been even slower with the GI crowd. I have had over the last year sending consult notes back saying, I had been saying, I think that they should be on one of these agents, GLP-1 or SGLT2, not for a diabetes reason, but for a liver benefit. And they would never commit. They would always say, we leave it to you. So hopefully that will change. I was particularly interested in, and I tried to get it quickly, where you were talking about weight. The benefit was noted independent of weight, right?
Yes.
Which I think is important and would be an obvious question. And the mechanism by which they propose that SGLT2 inhibitors reduce the incidence through the CD8 T cell. I got to admit, that was over my head. Somebody much smarter than me came up with that strategy. But it's interesting to have that proof of concept because I didn't know that. So thank you.
I added that last minute. I didn't know if I should have.
Perfect.
Zaren, you obviously know more about this subject than anybody on this call. Do you think we should be doing anything different at BC Diabetes? I mean, we use SGLT2 inhibitors widely. The only reasons we don't use them is if the patient's skinny, if they get a lot of urinary symptoms, or a lot of urogenital fungal infections. I know I was on a call with, I think with Mariam Kabutari about a patient who wanted to go back on DAPA who had a DKA, and I agreed with the client that if they started monitoring their serum ketones, I might prescribe it again for them. But should we be doing anything different at the clinic? The fact that we no longer measure AST, does that matter? Should
So for the, let me just open. Well, so the fibrosis four score does include the AST, and we do not measure it normally, but there are some people who actually have fatty liver or MASLD even with normal liver function tests. So it's really hard to say unless if they actually get some sort of imaging for it. Perhaps if they do have the risk factors of some metabolic, mostly are type 2 with obesity and other metabolic risk factors. Maybe not for us, but maybe it would be prudent to suggest to the family doctor to probably also screen for possible fatty liver or MASLD. And just, yeah. But although we are doing the treatment already with the SGLT2 inhibitors for other reasons, it would just be a good reinforcement of why we're using it as well. Back to that FIB4 screening, I think that was one of the pushbacks from the endo group, because actually in this clinic, CBC is ordered regularly, but most endocrinologists don't check CBC because they don't want, and I understand why. I was one of those, where I don't want to know about everybody's low hemoglobin. I don't want to get distracted and have to go chase that. But it was the same argument for we don't check an AST, and so the plea at the conference was if you could at least do it once a year. As part of your annual test to do an AST as well as ALT as well as a CBC at least that one time. I don't know if anyone picked up on it, but that's what the request was.
Dale, am I right in thinking that we do we still measure AST, but we just don't show it in our matrix, or have we stopped doing it?
But I don't think it's being measured.
Yeah, so the newer requisitions, the automatic one does not include the AST. I think the older ones used to.
Okay. Well, that's because I asked Sergey to change it. It wasn't by accident.
Which I think is actually the entire community did the same thing, because from an internal medicine perspective, it was a lot of, well, your AST can actually fluctuate a fair bit, and are we much more so than your ALT? Therefore, is it really helping, or is it sort of leading us down a garden path? This might be one opportunity where no, it actually does matter. So, and maybe it should be one off when needed. We should just think about it. I don't know.
Marla, are you on the call? We have been involved in a fatty liver study, obese type 2s, and they got MRIs of their liver, and they also got FibroScan where they measure the stiffness of the liver. Marla, are you on the call? Can you tell us our experience with that FibroScan machine?
Oh, that was such a long time ago. I don't think we were very successful with the FibroScan machine.
My take on
right now, I don't. I remember having it, the machine, and not really being able to really measure how much of the fibrosis it actually was getting. Yeah, I think that was the feedback that we got from that. It wasn't as effective.
I'll just make one more comment and then open it to the floor. I think as a diabetes clinic, we are very focused on glycemic control, and we've got all these wonderful tools now, and we should be using SGLT2 inhibitors widely and perhaps a little more than we do. Zaren talked about the importance of weight loss, and I know that if I had one of my gastroenterologist friends on the call here, he would say that weight loss is the single biggest factor. Interesting in the Chinese study that the control group actually did pretty well, I thought. You know, they had a fair bit of regression. Anyway, any other comments from others?
I know it's quite easy to get a FibroScan for reasons I don't entirely understand, but at the hospital, the ultrasound department is quite happy to do FibroScan testing quite readily. So that has not been a huge barrier. From a screening perspective, again, after that conference where I diligently for the last couple of months after the conference went screening, I was struck by the number of people who I was sure they were going to test high enough on the FIB4 score that I would need to send them for FibroScan. It was actually very, very few. So lots of people with kind of grumbling ALTs and ASTs never met the 1.3 mark. So the amount of referrals on for FibroScan maybe in a general diabetes practice may not be that high.
And Dale, this was our experience when we were doing the clinical trial, wasn't it, Marla?
Yes, that's right. Yeah.
We had our own scanning machine. Everybody was negative.
Yeah. Yeah. I do have a comment about the trial. In the beginning, you said it was stratified according to whether they were diabetic or they're not diabetic. And then the fact that they were not allowed to have GLP-1 at the very start. I think there's a little bit of information which we missed out on the basis that somewhere down the line, midway through the trial, they started to treat the diabetes as needed, but they were not elucidating on what measures they did. So it's kind of, they're not saying everything. They could have, whatever it is they did to try to improve the dysglycemia, they also tried to treat the dyslipidemia and the hypertension as needed. All of these factors all contribute to the metabolic syndrome, and that would have actually improved on the liver status. So they're not saying, I'm just catching it, like they're not really very upfront. I think it is a play of a lot of other factors which they're not mentioning. That would have contributed to the improvement of their scoring at the very end.
But Marla, I mean, it was a randomized controlled trial, and it did show pretty unequivocal differences. So the design supports the conclusion that dapagliflozin helped.
No, I'm not questioning the fact that dapagliflozin helped, but what I'm questioning is the fact that they were not very upfront with what they did to improve glycemia. Like they didn't state what they wanted, how the improvement was supposed to be, what they were aiming to achieve at some point, because all of that would have helped also with their endpoint.
Yeah.
That's my only comment.
Yeah, they didn't mention which medications they used to help control the glycemia, which, could have been a GLP-1. I don't.
Yeah.
Zaren, thank you for a wonderful journal club. You've raised the bar yet again for the rest of us. Thank you very much.
Thank you.
Thanks, folks.